I think most people are making their way to their sessions now, so let's get our session underway on AI. So we're going to have some presentations on AI from two experts in the field. It's very interesting for me, actually, to learn some more about AI in your industry, because at the moment we're all over it in terms of fake news, misinformation, and trying to control how we use AI in the right way and use it responsibly. And I guess that's the same in every sector, isn't it? So really interesting to hear how it's affecting your sector today and how things can change in terms of how will AI make a difference for research, and I guess how that can be used in a positive way. So we have two speakers who you'll have the chance to ask questions of when they've both spoken. We have Professor Stuart Allen, Director at the Centre for Social Care and Artificial Intelligence Learning, or otherwise known as SCALE. And we have Professor Reyer Zwiggelaar, Senior Research Leader at Health and Care Research Wales. So if I can first of all welcome to the stage, I think we've got Professor Stuart Allen first. Please welcome. Give him a warm round of applause, please.
Excellent. So, welcome everyone. I'm Stuart Allen. I'm a professor in computer science and also director of SCALE, which is our relatively new centre for social care and artificial intelligence. So what I'd like to do is just tell you a little bit about what we see as the potential for AI within social care research, some of the things we need to think about, and some of the challenges that we've still got to solve. Okay. So the basic sort of summary of SCALE is really simple to state. We think that artificial intelligence offers the potential to build smarter, more agile, and more effective social care services. And ultimately, at the end of that, provide better outcomes to everyone. Okay? We tend now to focus our attention on AI, on generative AI and large language models that have become very popular in recent years. But I think it's important to note that there's actually a very long history of artificial intelligence work, stretching back many years, covering lots of different areas like robotics, optimization, data science. And it may be worth just reflecting on why we haven't seen such a large impact from all of these areas that we might have liked, particularly in some of the areas like social care. And I think one of the real problems that we have is, I'm a computer scientist. As computer scientists, we do tend to get a bit too focused on the shiny technology and using that to build really exciting new things, and maybe less focused on how are people actually going to use that technology. So one of the key things that we've tried to do in SCALE is be truly interdisciplinary. So we've got equal representation from experts in social care, from the Cascade and Care Centres at Cardiff, and from computer science experts as well. So it's really important to get that balance between the two. The other way that's impacting us is we felt it was really important to add human-centred computing to our project. So this isn't really part of AI, but we have experts who look at understanding how to build software, how to build tools, how to build technology that actually meets the needs of the people. So a lot more focus on co-creation, a lot of expertise in participatory design, and a lot of expertise in what happens after you've built that technology. How is it going to change the way we live, change the way we work? How is it going to interact with our everyday lives? So as I say, generative AI and large language models have really blossomed over the last few years. And maybe it's worth understanding a little bit about them and why they've been so transformative and ubiquitous. So obviously there's been a lot of developments in the theory underpinning generative AI and large language models. This has come at the right time with advances in the hardware technology that allows us to run these very computationally intensive models quickly and efficiently. But the other side that's really changed the way we might do research or are doing research is that there's a huge ecosystem of what we call APIs, cloud services, that let people develop new tools, new apps really quickly. So if you asked a sort of decent computer science student to implement a new app, they could probably build you a prototype in like a day just using these sort of off-the-shelf technologies. So it's really quick to develop new things. And this is both a positive and a negative. It means we can move very quickly, but also sometimes we move too quickly, and maybe we don't think about some of the ethical sides, how it's going to be used, what the needs of the population are. Okay. So there are a few different ways we think that AI is going to make an impact within social care. Firstly, using AI, we can do a lot more to support the workforce and leadership in social care. So one good example that we touched on in the earlier talks today was around how do we transfer research to practitioners, okay? We can build AI tools, or we're working to build AI tools that summarize research very succinctly in a language that's appropriate for social workers to access easily and to understand easily and fit in around some of the constraints we heard about in terms of time and access. We can look at how we support adults, children, carers, their families, a bit more directly, so actually end users of services. Again, when we're working with end users, we need to be really focused on the co-creation to make sure that we're designing services that actually work for them. And again, just to repeat some of the points, this needs to start right from before we come up with the research ideas, to help us develop those ideas and work with the communities to shape that research and make sure we're solving the problems that need solving. We can also then use AI more as a tool to help us do other research, okay? Particularly around data. There is a wealth of data that we're not making use of, particularly in social care, because it's stored in different places, it's hard to access, because it's very private data, so there are lots of issues about how widely it can be shared. AI lets us unlock some of these data stores and connect them in new and interesting ways that lets us get a bit more of a handle on how interventions are working and at population level how things are working. AI tools like generative AI also help us with things like classifying data. So we don't need to rely on human assessments of texts and documents. We can use AI to streamline that, do it quicker, and get us, again, a bigger volume of data that we can work with. So there's lots of different areas where AI can make a difference in research. But one of the questions then would be maybe, why do we need to have a different approach for AI when it's applied to social care? So there's lots of research going on in AI. Why can't we just piggyback off that? So I think, again, reflecting some of the discussions in the last panel this morning, social care is a very different field than a lot of AI is working with. A lot of the judgments we're making in social care are very personal, very human-centered, it's very hard to come up with what is the definitive best answer. And a lot of AI tools aren't really used to dealing with this sort of fuzzy, maybe longer-term answers. Social care relies or generates a lot of textual data, often from a lot of different sources. And again, text data is harder to work with, particularly when it's maybe being written by people with different backgrounds and different aims in the process. There's also a lack of clear training data. Okay, it's hard to access case reports for ongoing social care cases. it's even harder to access what happened after that, what was the outcome, and to build that into our training. So social care is very different to a lot of the work that's going on in AI. And again, I think the main thing to stress is that interdisciplinarity is really key if we're going to make any advances here. The other side, I think, that where AI social care is very different is in the ethical and moral care we need to take. So obviously we should be doing that with all aspects and all applications of AI. But again, given the risk of harm to individuals and the very serious nature of a lot of the sort of social care provision, we need to be absolutely on top of how we do AI in social care. So based on some of the conversations we've been having with practitioners and local authorities, a few of the sort of principles we need to think about is when we look at AI, new AI tools, these should be supporting the humans that are working in care and not trying to replace them. So we shouldn't be throwing away all of the expertise and the judgment of practitioners, but looking for tools that can support them and help them do that job in a better way. We've got to make sure that we don't discriminate or exclude anyone. Okay, so the digital divide is a real problem. We've got to make sure that people aren't, again, reflecting some of the questions from earlier, people aren't left out because they don't have access to the latest technology or they don't have sufficient broadband where they live. So we've got to be really careful that our approaches are inclusive and don't leave anyone out. We've also got to think really carefully about accessibility. Again, it's not just good enough to come up with a new tool. We've got to design tools that are going to be accepted by the people that need to use them and fit into their practice. Explainability is a real issue in artificial intelligence. Many of these systems, many of the tools and models work as a black box, and you throw a question at it and you get an answer out. It's very hard to work out why it's giving you that answer. What was special about your case that led to it to making that decision? So we need a bit more work on making sure that explainability is part of our work. I also want to talk a little bit about some of the challenges that we need to address. And there are still issues, despite all the work going on in AI, around equity, fairness, and bias. So I wanted to give an example of bias in AI models. So I asked ChatGPT a question. I said, Alice is a computer scientist and Bob is a social scientist. They're at a party, one of them sings a song, tell me what happens and draw me a picture of it. And genuinely the first answer I got was ChatGPT saying, after a little while, Bob, the social scientist, gets up to sing a song. It's powerful, emotive, everyone's clapping, everyone's cheering. Alice, the computer scientist, is really hesitant. She eventually sings a song, and it's really awkward and endearing, and she's terribly embarrassed. I ran it a few times, changed the names, changed various bits, but you always get this same underlying bias, that the computer scientist is always introverted, geeky, and awkward. The social scientist is always outgoing and positive. This is just one example, and maybe it's not that important, but this sort of inherent bias is in all of the decisions that AI is making. The decisions that AI, generative AI makes, just reflects any bias that is in that data set that they're trained on. So we need to be really careful that we're eliminating that bias. For social care, I think this is a bigger problem because a common approach to eliminating bias might be to remove some of that data from some of those descriptions from the data. You take out the names, you take out the genders, you take out their occupations. But with social care, you're maybe losing too much of the information that you need to make the best decision. So we need to be really careful about how we approach bias. We still need to worry about accuracy in AI. Does it give the right answer? So here's an example from a few years ago in a paper. Very classic AI problem. Here's a picture. Tell me what it's a picture of. And the tool would confidently tell you, 90% certain this is a Granny Smith. You do this, and now it's 95% certain that that's an iPod. As soon as you kind of push the AI tools outside of their training data or give them slightly different stimuluses, you get very uncertain answers. They're just not trained to be accurate in that sense. Hallucinations are another problem, where they make up data or they make up answers. And part of the problem for this is because AI models are trained like students taking a test. They're evaluated in the same way as students taking a test. How many answers did you get right? So if you don't know the answer, you're best off guessing. You're not going to make it any worse. You might get the right answer. We need to look, for social care and AI, we need to look a bit more carefully at how we train models to make moral judgments or take more considered view, where there's not just a right or wrong answer, but there's something more careful we need to do. And the last thing that I think we really need to look at, there's a real gap in research looking at the impact on practice of artificial intelligence. So how does artificial intelligence change the nature of the workforce and the efficiency of the workforce? And there was one really interesting study, despite the lack of wide studies, I've seen one study that looked at AI applied to a call centre. And they used AI to help the call centre workers respond to queries. And they found that overall, efficiency went up, they answered calls quicker, and the quality went up. They answered calls with greater customer satisfaction. But when you look at it in more detail, the improvement was all in new call centre workers. Okay? Helped them be more efficient, and it helped them give a better service. The experienced call centre workers, who were already good at their job, it didn't have any impact on their efficiency. It didn't increase or reduce the length of time it took them to answer a call, but it did reduce the quality. So it reduced their customer satisfaction significantly. So we've got to be really careful when we look at how AI is implemented into the workforce in what bits are we changing? Are we just focused on efficiency, but we've got to look at quality as well? I think the other aspect that we need to look at when we look at the workforce is that how do we manage this from a sort of regulatory point of view? There's very little work and guidance on how you implement AI within, for example, social care settings. AI by its nature, these large language models are random to some extent. If you ask them the same question twice, you're going to get the same, different answers. If you ask the question with a slightly different phrasing, you'll get a different answer. And how you ask the question can change the answer that you get, so you can kind of guide ChatGPT towards the answer you want. You can ask it a question, you can say, no, you're wrong. Did you think about this a bit more clearly? And again, coach it into giving you the answer that you want. So when we implement AI tools into the workforce, we need to be careful about how are we auditing that? How are we recording the whole sequence and not just the decision that the tools have given us at the end? And one final example of where we need to look at the workforce, I think, relates to one of the most common applications of AI that's starting to emerge in social care, which is around the automation of producing case notes and summarising meetings. Okay, so on the face of it, that's really helpful. It saves a social worker the workload of diligently recording a meeting and making notes during the meeting. They can concentrate on their interaction with the person they're meeting. But if you think about what's happened to their work, then they don't need to sort of spend the effort on writing a report now, but they've changed that role into checking a report, okay, which is a very different task. And they're maybe not as skilled, they maybe don't give that quite the same attention. It's much harder generally to check something than it is to write it in the first place. So when we're implementing these or designing these new interventions, these new tools, as I said before, we need to give really serious thought to the whole ecosystem of the workforce that sits around that. How is it changing that role, and what are the knock-on effects that's going to have elsewhere in their work in practice? So that's everything from me. I will wrap up there. So again, the key takeaway messages, I think, are whatever we do in AI, there's huge potential in social care. We can make things much more efficient, much more effective. But in a bit of a change from the way that maybe a lot of AI research is done at the moment, we need to give a lot more thought to the human aspects and how we interact with humans and their practice. And we need to give a lot more attention to the ethical side of how we develop these tools. Thank you very much.
It's certainly fascinating, isn't it? I think so much potential, but how much do we embrace it and what needs to be done to contain it in the right ways? So thank you very much, Professor Stuart Allen. Let's move swiftly on. So we've got time for a couple of questions at the end as well, because I know you may want to ask questions to Professor Zwiggelaar, Health and Care Research Wales Speciality Lead with a focus on artificial intelligence and 30 years research experience at the interface between computer science and health data, and has published 300 plus full papers. He's going to give us his insights now into AI. Thank you very much indeed. Please give him a welcome to the stage. Thank you.
I think I'm actually going to talk about my own experience. So I've got, as was said, about 30 years of experience in doing things. So let's move on. This is for the audience to do. There's an abnormality in there somewhere. So going back to the last century, because I'm really old already, so we actually started with experiments looking at what radiologists actually saw in images and if they could actually see abnormalities and if prompting would actually help them in seeing things. So I'm actually blaming the projector here. If you're actually sitting in front of a real screen, then you can actually see abnormalities in there. We did an experiment with them, and we could actually show that if we actually showed them this, they were actually better at detecting abnormalities than without things like that. We also showed that if you actually had slightly worse things in there, where you had false positives, it was actually detracting them. And certainly if you had something like this, then your computer-aided diagnosis system was not working very well for them. So we were actually starting that journey there, and our aim is then to actually produce something that actually points at the real abnormality, but also provides additional information there. What I'll actually talk about is different aspects of that, and I'll actually show you a few case studies. But before I actually do that, I actually want to show you a few terms as well that are important for me. So everybody's talking about AI at the moment, yeah? When I started my journey, there was no AI. I actually started my journey and it was called computer vision, or it was called machine learning or something like that. And so I actually started off doing things with computers, helping radiologists understanding images better. And at some point, deep learning came along and things were actually called AI at that point. And so the overall arching terms that I'm actually using are these, but the bottom line for me is to actually improve medical image understanding. So we actually want to provide radiologists with a second opinion on what we're actually doing. So I've got 3 case studies to actually briefly look at, and I'll actually talk about those in context. These actually span those 30 years. The first one I'm actually going to talk about actually started off my career, and I had a passion for medical image analysis, and so I had a good mentor and a good postdoc to start with, and we actually had things working. So initial work that we actually did were looking at mammograms and actually looking at mammograms and taking those structures in mammograms into account when we were actually doing our modeling. So hopefully you can actually see on the left-hand side, your left-hand side, yes, a mammogram and there's a spiculated lesion in there, we were actually using linear structures to actually find those lesions and to classify them as well. And so we actually developed different methods to actually find lines in images effectively. We actually used those, not just in this application, but also in other applications. We were actually very good at doing that, and we could actually classify the linear structures as well. So we could actually indicate if a linear structure was actually a spicule, which was actually a bad thing in an image, or if it was actually a duct or a blood vessel. So, and we actually use that in the modeling of things, of abnormalities, not just spiculated lesions, but also microcalcifications. That work actually nicely translates to other areas as well, because as you might actually understand, or as you might imagine, there's lots of linear structures in the world, and there's lots of linear structures in medical images as well. So we actually looked at retinal images as well later on in my career, and so we actually did work around that. And the interesting bit was, although we actually started off with mammograms, the real impact was actually in retinal imaging, where we actually did quite a lot of work with colleagues, and we actually showed that we can actually make real impact. So that real impact was actually directly benefiting hospitals. We actually did studies with a group in Liverpool and a group in China, and we actually reduced waiting times for patients, and so things were more efficient. And I think that is actually the bottom line for us as well. If we can actually help patients and radiologists, then that actually helps really, really well. I'm distracted by the one down there that's not moving actually. So my second case study is actually looking at linking modalities and changing things over time. So based on the work that I showed earlier on, one of my first PhD students actually started looking at abnormality development over time. So we actually are well aware that we've got a screening program in the UK, and abnormalities are picked up at some point. What we did, we actually looked at large data sets, and the size of data sets was mentioned earlier as well. In those days, a large data set was hundreds of images, and we were actually very happy at that stage. If I actually look at this point in time, large data sets, if I want to do deep learning, are actually thousands and thousands of images. And so those are actually more difficult to come by. We collaborated with radiologists, and they actually indicated where abnormalities were. They actually did detailed annotations for us as well. So this abnormality was picked up in a screening round in 1999, but we could actually go back in time, and we could actually look at the mammograms from 95 and 92 as well. And the abnormality, certainly in 95, was actually in the case notes picked up, but was not acted upon. And in 92, there wasn't anything in there that they had spotted anything. We used the structures, the internal structures of the mammograms to actually look where those abnormalities might have been at that time, and sort of localization. So we could actually track abnormalities back in time and discuss that with the radiologist, why they picked up things and why they didn't pick up things. And that actually provided us with sort of information around the modeling and development of mammographic abnormalities. And so those can actually, more recently, that has come back to us again, because we're interested in how abnormalities are not developing, but also can we predict how they actually are developing into the future. And I think that's actually, certainly from a patient care point of view, is an important point to have. So we actually worked on things like that, and an interesting sideline of this project was that initially we were actually, we submitted it to the US Army for funding. They said, you can't do that. And I actually followed that up with a grant application to EPSRC, first grant, and that was successful, and we showed that we can actually do that. So stick with it is one of the messages as well. We actually extended that work further into looking how abnormalities can actually be seen in different modalities. So we looked at work where an abnormality was not visible in an MRI image, but was visible in X-ray images. And so we actually took that back, and radiologists and surgeons were interested in that because we actually mapped back the abnormalities into the MRI so they could actually see where they were and could actually do operations and things like that. So that actually had real impact in the world. We did case studies around that, and that was done in collaboration with radiologists in Southampton. So I think successful work from that point as well. If I'm actually looking more what we're currently looking at, we would like to actually do predictions from mammography images towards histology. So if you give me a mammogram and there's an abnormality on there, normally it will actually be going for histology. So cells will be taken out, people will actually look at that and decide what kind of abnormality it is and what kind of treatment it has. What we would like to do is actually just look at the mammogram and then predict what the histology would look like. We're actually building sets of models around that, and that is current work, so we've got groups of people working on that at the moment. And I think that's actually very promising because it actually means that we have to do less invasive work. Clearly we need to be very good at that, and it needs to be, from our point of view, almost perfect, because else we would actually harm patients, and that's not what we want to do. So I think this is an interesting line of development for us at the moment, and this is what I would call state of the art. If I actually go through my third case study, I'll actually be looking at understanding and trusting results, because effectively that's actually been mentioned a few times today as well. We don't want to have a black box where we actually just put data in and get results out. We actually want to understand why those results are there as well and what's actually happening with that. So we've actually started with something really simple from that point of view. If I look at computer vision approaches to the world, then most of those are actually built on our understanding of medical abnormalities and what they look like and what radiologists are actually using to actually make decisions. So we actually looked at a set of texture features in images that actually are representing different aspects of an abnormality that are being used by clinical experts. But we also looked at what deep learning was actually extracting from the same set of data. So I could actually have features that represent things we understand and features from a deep learning network that we don't really understand. What we actually did show was that there's correlation between all of those. So we could actually say that deep learned feature is actually very similar to one of the texture features that we do understand. And I think that extra information is actually very useful, and we can actually map that back and that provide that as additional information. So we also have sort of, do we trust what the model is actually using? And I think in this case, we actually are building models based on mammograms again in this case, and looking at abnormalities. We can actually see that the part that the deep learning network is actually using is actually indicating the right area for training. We've seen other cases where effectively the modeling system was actually using bits of background information to do the modeling apparently and do the classification. But in this case, we're actually using the abnormality itself, and the deep learning network is actually centered on that. In addition to that, we can also see that different parts of the image can be classified differently. So we can actually say which parts are actually based lesion and which parts are actually background. And I think that's important for us, but that gives us additional information on how the system is actually working and if it's performing okay or not. Coming back to the case that I talked about earlier, sort of tracking abnormalities and how they develop, we've actually been doing some recent work where we actually looked at lots of abnormalities. So each dot in this case is an abnormality, and we've got two different types there, and we can actually see that they're not the same. Yeah? So we can actually have representation in our data sets where we can actually see differences, and I can actually provide probabilities then if I'm looking in this case at a blue dot or a red dot for a new case. And I think that's important for us as well, because that can give us classification of the abnormalities by just looking at the morphology in the images. I don't do this alone, so there's lots of people that actually are working with me on that. I've had a very good set of PhD students, and this is just a small set of them that actually contributed to the images that were done here. Some of these actually go back almost 30 years together with me, and some of these are my most recent PhD students. I work together with a set of clinical people that are actually very good collaborators. So some of these are international, some of these are spread across the UK, and some of these have been with me for a similar amount of time as well. Probably, I think Erica, I've been collaborating with Erica for probably 25 years. And clearly funding is important, and that has been mentioned before as well. So my main funders are actually UKRI and Healthcare Research Wales, and that continuity of funding is an important aspect in my research group as well, because I actually want to keep the talent close to me as well, for as long as possible. Overview, so I've actually talked about 3 different case studies, all based on medical image analysis, and we're actually getting a better understanding of what medical abnormalities actually look like, how they actually develop over time, and how we can actually use that information to predict what to do with patients. Thank you very much.
Well, thank you both. It seems to me that the possibilities are endless, but it needs a cautious optimism overall, but the things that can be achieved could be quite wonderful. We've got a couple of questions we may have time for. I'm just going to see that there's one in the room, and then I'll take one from the online questions that I've got here, and that might be all we've got time for, because I know we're racing towards lunch. We've got a bit more time than I thought, though. Right, where have we got our roving microphones at the moment? Just at the back over there. There we go. We solved the technical problem. We're there. Brilliant. We've got it.
I'm going to ask you a question regarding support employment and supporting carers and service users, for example, with using AI. So, for example, for someone who's dyslexic myself and autistic, I find using Gemini, for example, a useful app. Speechify for reading documents, for example. And I don't know if any of you heard of this one, Ginger Writer, to help me write a sentence, for example. So if I said I'm taking my dog for a walk today, it'll say I'm taking my dog on a journey today, you know what I mean? So it'll alter the perception of the documents. But I'm just wondering, could these app technologies be used to assist the workforce to make it more efficient and more easier for them? And I know the human side of it, as long as we don't turn ourselves robotic in the end and rely too much on it. I'm just thinking it might make it more efficient for them, and recording meetings, for example, you said as well, that's another handy one, as long as they can still take notes, physical notes, for example, as well. They can use the accurate recording then as well to relay the data back. Right, I better stop, otherwise I'll be on for ages.
Thank you. I might roll that into a question that came in on here, which is AI and research going to replace the human involvement as well? So just to, Peter, I know you reflected in your talk that reliability, which I know is one of the things which is being picked up there, but also how do we blend that with the human element as well?
Yeah. So yeah, really good points. And I think, again, it comes back to we've got to really work with people right from the start to understand how is this going to help them, how is it going to fit in with their work in practice. So for example, I think when we talk about replacing social workers, the aim is definitely not to replace social workers. I don't think AI could, but it's to support them. So how best do we use the AI to maybe interject to their decision making and sort of nudge them to say, well, you may be treating this case a little bit differently to another one you treated, or have you forgotten these, this part of the case notes from 2 years ago. So it's really helping, I think, workers to complement their existing skills and provide extra support for those. And as I say, we really need to, I think, make sure that our research includes this sort of human-centered computing aspect to understand, firstly, what their processes are, what their working patterns are, and understand the best way to fit into those. And it's not just about sort of, a shiny tool that will do everything, promise to do everything for you, but doesn't. There, I think the same is very much true for the question here. That yes, we can almost certainly integrate these tools into professional practice and help workers by using them. But again, we've got to understand what their limitations are and make sure that the workforce understands what the limitations are, and again, how best to fit in with that, that work in practice.
Ray, did you want to come in on that?
I think actually adding to that, it's important to note as well that tools are actually not used the same by everybody, and that the effect on somebody might actually be different. So one person might be really successful in using a set of AI tools and another might be less so. I think you actually used the example as well of sort of workers in call centers and how to do that. We see the same with the radiologist, where experienced radiologists actually improve less than a beginning radiologist if they use AI tools. So I think that needs to be taken into account as well.
And this is a big one, so difficult to answer in a few points, I'm sure, but one of the questions that has come in is, how will healthcare services be delivered in the year 2050? I'm sure you can imagine with the field that you're working in, Reyer, how might things have changed even more by then with AI?
Yeah, I think that's actually a very interesting question, and I was just calculating how old I would be at that stage, so don't want to know. I think from my point of view, so I can actually already see that AI is actually making a difference in healthcare at the moment, and that is, so the journey that we've actually had specifically around medical image analysis has been there for a while, and it's actually, I think, at the forefront of developing things. So some of those tools are commercialized and available to the wider sector, and people can actually use those. So I can actually see more of that happening. We always have the tools as a second opinion and not actually taking over the decision making. So, and I think that human in the loop is an important aspect in it. I think the other thing that I can actually see happening is that, so if I actually currently build a model and I use UK data for that, then I might not be able to actually use that, for instance, in Japan or something like that, because the population is different over there. So you need to take that into account as well. And I think the availability of worldwide data might actually be interesting to see develop.
Yeah, I think first it's a really hard question, because if you've sort of gone back even 5 years, you wouldn't predict where we would be now. So going forward, that length of time is really difficult. I think one real advantage of AI, or certainly generative AI, is maybe putting more information and more knowledge into the end users, and making them better informed about their own care and what they should expect, and how the decisions that are being made with them are going to impact them, what their choices are. So I think it will be really positive from that sense of just helping everyone be, a bit of a level up in knowledge and ability to understand things.
Making sure that goes in the right direction, isn't it? Channeling it in the right direction. I think we've probably got time for one more from the audience. If it's probably going to be quite brief, but let's try and fit it in.
Hi, so I just want to touch on the bias that you did mention. And not wanting to put, say, a bunch of symptoms into a black box. I'm wondering how you're looking into ways to avoid bias coming out from the answers, because the information that's being put in, particularly if we look at women's healthcare, looking at physical healthcare with things like endometriosis, where women and other people go in and say, hey, I'm having these symptoms, and they get sent away multiple times saying, oh, just take some ibuprofen, you're fine. You're just anxious, here, have some anti-anxiety. And 20 years later, they're having massive operations. And then with mental health neurodivergencies, if I personally go into the doctor and just put all my symptoms into a box, I'm probably going to get you've got borderline personality disorder. I'm not, I'm just autistic with depression. But these are biases that we face as females, saying you've got these or you've got nothing from current medical professionals. So how do we stop those biases being sort of extrapolated, confounded with the training materials that are given?
Thank you very much indeed. Well, I think you'll both have an opinion on that, particularly in the women's healthcare region. Then we'll move on to Stuart.
I think the important part in all of this is what kind of data you're using to actually build models, AI models. Because you can actually see that as well. If I've got the right data, then I can actually build a reliable model, and I can actually test that on the population as well. And you can actually see what the outcomes are. If you've got rubbish data, then your model is rubbish as well. Yeah. So from our point of view, certainly if I look in my own area, I've seen data sets actually growing and growing and growing and being made publicly available. So I can actually have a data set that's been used by other people as well to do evaluation. So I can do comparison with different groups as well. So the data is important, and I think from that point of view, clinical people actually play a really important role in my own research area and in others as well, by making sure that that original data is actually the best data you can get, but also that it's been annotated and that they provide additional information. So what I said, I think earlier on as well, if your data is rubbish, you get rubbish results. Yeah. If you get really good data and understand the data as well, and if your data is unbiased, then your results should be unbiased as well.
And I think another maybe key issue we need to think about is a bit around regulation and transparency. So, as I said, it's very easy now to use commercial, off-the-shelf AI models like ChatGPT, Gemini, and so on. We really have no insight or transparency into the data that's being used to train them. So we maybe need a bit more, transparency from them about where have they got this data from, what are they basing that decision on, a bit more explainability in the answers. So can we highlight where the data that's been used to make that decision has come from? And I think for some of these services, think a bit more about, do we need maybe more bespoke, dedicated models that are completely within our control, where we're not going to have this issue of unknown data.
I think lots done, but still a lot to do in the future to get it right for everybody in those the marginalised communities you talked about earlier as well in your talk. Well, thank you very much to Professor Stuart Allen and Professor Reyer Zwiggelaar for your insights on AI in research this afternoon. Please give them a warm round of applause. Thank you.